listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years experience. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone back to the Medic Materials Podcast. Gerard, I'm going to take those so you can't mute yourself no more.
I forgot I had the old volume knobs on both sides.
Stroke.
Turn them right down.
It's just not fair. Yeah. I like to see you have your seizure when you listen to your voice.
I hate that voice.
It's so much fun. So, first off, we have Gerard here.
I should start smoking again so I can change my voice like this.
Yeah, you know, you could sound like Batman.
Oh, fuck. Yeah, I would too, right?
I need a cough drop. I'm Batman.
Could be worse. I could sound like Bane.
So we have in studio here our favorite,
Kelly.
What was that, Kelly? Oh, that's right. The other girls are bitching out.
They are bitching out.
Why? Because
It's a big old sausage fest today.
Well, I mean,
Minus Kelly.
Well, she likes that kind of stuff. Yeah, she has her own OnlyFans. I heard. You know,
Really?
pretty hot. Yeah,
Kelly.
yeah. Hey,
Gosh.
you got mouths to feed.
I mean, you know, it is a tough economy. You make it where you can.
Yeah, man. You know, one
So-
too many times with Chad, and a couple little mouths to feed.
You know, why is it always Chad?
Fucking Chad, man.
Fucking Chad.
Yeah.
I'm sorry, Kelly. We should have left you not
Yeah.
in Chad.
It could be worse.
It could be worse.
Could be a Kyle.
It
Could be.
It could be a Kyle.
That was the generic Kyle, the royal Kyle, not the Kyle. Let's be specific about that.
That one we do need to be specific about. We love you, Kyle.
That's right.
So just make it a Justin.
Yeah, there we go.
There you go. So
Living the Justin life.
living the Justin life. So with that, Gerard, I'm going to pass it to you because you have a
Always
very
to the left.
special, very, very special guest that's joining
I
us
do.
in studio
We
here.
do. We
do,
are
yes.
now blessed by his presence.
Yeah.
The grand, exalted Mahabuchi of cardiology, the Sultan of Sgarbossa, with us once again, dropping knowledge and chronic flakes on that ass.
Jesus fuck. I feel like we need a more epic thing. Like, we need like The Rock or something, like in the background. Being like,
Smell what the Butch is cooking.
But I will say, Butch has the most epic theme song ever.
It is the greatest theme song of all time. We should say, fuck him, take it, and use it as ours.
I mean, I wanted to. As
Yeah.
soon as you sent it to me and was like, this is Butch's intro, I was like, this might be our theme song next year.
Yep, I would.
Oh, it's so good.
You should.
I might have to write the orchestra that does this just so we can steal it.
You got to write in Arabic, but yeah.
Whatever. I'll
Good
do
stuff.
it. Dude, when you watch this video, we'll send it to you. If he didn't already do it,
I didn't.
fucking the conductor was smoking.
I know, right?
Like, and you don't see that from,
I know.
like, you don't sit there and go, an orchestra conductor. Ha, ha, ha.
I bet she really knows how to tell you what to do.
Woo!
Woo!
You know, like,
Yeah.
nope. Oh, my damn.
Conduct me. Where are you poking that thing?
In the exit. But yeah, so
I
Butch,
literally just had like a vision of a flight attendant. The exits.
so yeah, Butch is one of our coworkers as well as is that your grand poobah
Grand
title now?
Exalted
I forgot the
Mahabuchi.
Maha
Sultan, I
Butchie?
forgot the Sultan hat, but he's right.
You need a freaking golden microphone if you're going to be the Maha Butchie.
Yes.
But yeah, so we brought you in specifically to talk cardiology, and it's going to be a very exciting episode because one of the things that we don't talk about a lot is EMS's like 1/1,000,000th knowledge of what they should know about 12 leads and cardiology. And it really, like, we all have talked at this table on how much we don't know. And the sad part is, like, you and I, Gerard, we're very humbled when we talk to Butch because we don't know what we don't know.
Yeah.
And then he's like, yeah, this, and yeah. And I'm like,
Sure,
that sounds fabulous.
fantastic. Concordance and discordance, yes.
Right.
Right.
You know, axis deviation. I still don't understand axis Nope. It says it on the thing. I don't know what it means.
It's going left. It's bad. Why? Because the Mahabuchi told me it's bad. Let's get that shit back in order.
I mean, it's left is good in NASCAR. So it's good sometimes.
Well, I mean, that's really all they know.
They have right turns.
Do they?
They have like 2 road courses now.
I know.
Where they got to go left and right, up and down.
Okay, well,
you know,
progress.
But yeah, so there is no Kelsey, so there's going to be no rig check. So I'm going to do the,
slacking.
I know.
Look at Kelly giving the two middle fingers up.
Seriously, she's going to be putting in a lot of effort in this episode.
This is all you, baby.
Yep, but because we're talking a lot about I'll hit myself
Isn't
on
that
that
where we
one.
killed Bin Laden? I'm pretty sure that's where we iced Bin Laden.
So
What
yeah,
a dog.
So, about. But since we're talking
with a fucking stroke,
since we are talking a lot about cardiology within the next hour, I'm going to be posting a lot of what we're talking about in picture form because this is radio and that is what it is.
Cardiology Appreciation Month.
Exactly. Yeah. So make sure that if you're not already following the Instagram and or the Facebook, make sure that you go and do that because I am going to be posting a lot about what we're talking about on there. So it is at Medic Materials EDU for both platforms. So make sure that you go and follow us. So I was going to ask the paramedic intern Kelsey this first question, but
you suck. Yeah, jackass.
She's not here, so I'm going to just throw it off to you guys.
Kelly just gave her the suck it.
Why don't we just have an EMS wrestling podcast? Right? I mean, really, really. So, yeah, I want to throw it out to you guys in just how hard overall is the 12 lead, like how hard is it to learn? And then once you learn it, in air quotes, the ability to read it in the field and read it like successfully. How hard is that concept?
Oh, everybody looks at me.
Emily's
not here, Kelsey's not here, and they still look at me.
Yeah.
All right, fantastic. All right, well.
I mean, he did it first.
Well, for me.
I looked at him.
For me. Yeah, I mean, learning it isn't, it's not overly complicated. Learning basic stuff, but there's so much on there that you can read and interpret. It's like you could have a whole freaking semester of paramedic school just on that alone, just on, interpreting different issues from, an EKG. And, I mean, the basic stuff, all right, elevations, depressions, and, big T waves, little T waves, wide stuff, skinny stuff, it's fairly straightforward, but then there's
sounds
so
like a
much
good dating.
Right. Fat stuff, skinny stuff. What are you into? Double stuff.
Sweep right, sweep left.
Yeah, like the 12 lead dating show.
Right, yeah.
Next reality series coming from Medic Materials. Starring Gerard.
Speed dating, somebody with a STEMI. All right.
All right.
All right. Don't make me. All right.
Just do it. I know you want to.
McConaughey, he's just right here talking about things, He just keeps on living at VIN,
Anywho.
It's better when it's on the radio to dispatch. That's route 303. We're back in service. Roger. I just like them dispatchers. I keep getting older. They stay the same age.
So going to you, Butch, like this is your thing. What would you say to that?
See, the problem is with this whole 12 leads and cardiology and stuff, they literally take you in class and they're like, okay, here's what you're going to learn. You're learning the basics. And they're like, have fun. You know, they literally just teach you the basics, how to treat the basic stuff, bradycardias, tachycardias, you know, and your basics, your STEMIs, inferiors, laterals, you know, and that's what they teach you. And then they let you loose in the world. That's what they do. And the problem is you have cardiologists in the world that can't agree on one strip to the other. I mean, they still have people out there now that if you poll them now, you know, 50% of them still believe you can't, you know, read a STEMI in a bone branch block.
Right.
Now, even with all the material that's out there. So, I mean, how can they expect us to be able to do our job when they can't even get
on the same page?
Right.
Oh,
yeah.
Right. I firmly remember a freaking code that I had worked when I was still an EMT. And by the time the hospital had finished working it had been 2 hours that this guy was being worked. Mm-hmm. And there were two cardiologists standing in front of us. One had just completed doing an ultrasound, and they were arguing. Like, I thought they were going to have fisticuffs. They were like one was certain that there was still some kind of, you know, muscle movement, and the other one's like, no, it's this, and no, it's that. And, you know, we're going to, you know, and they must have printed off, you know, like a fuck ton of fucking 12-lead EKG strips, and they're, you know, flipping through it like it's fucking War and Peace, you know, going back and forth with each other. I'm just like, yeah, I mean, they two guys right in front of it, they could not agree on what they were looking at.
Right.
You know?
And that's kind of the nuance of 12 leads. It's like, it seems so straightforward, you know, and I think that's where it gets a lot of people is you learn the basics, and then, like you said, they kind of let you go in the world knowing what you don't know.
Absolutely.
And then, everybody goes, yeah, well, you know, I know how to read a 12 lead. They taught me. I'm cool. And then they never look at anything else. And, you know, Gerard, you said you could almost run an entire semester on 12 leads. I think make it an entire different class.
Yeah.
You know, take your paramedic, pass your paramedic, make you go to this class.
Yeah.
You know, why not? Because, again, it's only going to help find things that you can possibly be helpful with.
Yeah. I mean, I've been doing this, you know, 5 years now we've been doing this.
Yeah.
And I'm the first one to raise my hand and say, you know, hey, what's your weak spot? Cardiology.
Yep. Yeah, man.
I know just enough to be dangerous.
Yep.
You know?
You and me both.
Yeah.
And I, like, you know, I literally walked upstairs right before we started recording. I looked at Jess and I said, hey, there's an empty chair. We can kick Kelly out.
Right.
And, you know, she's like, oh, what are you talking about? And I was like, 12 leads. She's like, fuck no.
Right.
And, you know, I was like, what? She's like, you know I'm terrible at those. And I was like, I'm terrible at those. That's why we have Butch.
Right.
So we should just get you a Google phone number and make it the Butch lifeline for cardiology.
Right.
Like, hey, Butch, I didn't call the doc.
Call
I
me
called
now
you.
for your free reading.
Yeah, man.
Yeah, man. Oh, man. How many people in our audience remembers those commercials at 3 a.m. in the morning?
Wow.
But yeah, so, like, when do you guys, when specifically do you guys go to the 12 lead? Like, other than, like, is it every single time there's chest pain, or do you branch out? Like, I'll branch out. I'll take this one first. Like, I love to branch out any type of, like, altered mental status or shortness of breath or chest pains. I'm doing it. I even do them sometimes after seizures, depending on, like, if they're super postictal and they're taking a long time. You know, if they're postictal for 5-7 minutes, then I'm like, whatever. But if they're upwards of 20, I'm like, why not? Even if it's going to say normal sinus rhythm, cool, whatever.
Yeah, I mean, it's not just, you know, chest pain equal 12 lead, you know.
But I think that's what a lot of people think it is.
I mean, for me, yeah, I mean, altered mental, generalized weakness. You
Good
know,
one.
especially with females.
Yeah.
You know, females are weird, you know. And Oh,
Breaths.
I feel my legs just feel like lead weights. Oh, really? You're getting a 12 lead.
Yeah.
You know? Yeah, any kind of altered mental status. I mean, so many different things that I would just, and there's sometimes I would just like, you know what? Something's going on here. I'm just going to, let's rule that out.
Yeah, something doesn't feel right. Why not?
Let's just make sure that it's not the heart.
Yeah.
You know? So, I mean, yeah, there's times I do it, you know, where maybe it's not indicated. But then again, there's also times where, you know, someone could have, a lower abdominal pain and, there's no pain on palpation. There's no pulsating mass. There's none of that shit, and, they're waiting for you standing up outside, the ambulance when you show up on the phone.
Yeah, right.
I'm not doing a 12 lead on you.
Yeah.
But then there's, oh my God, you should have done a 12 lead. The fuck I should have.
Yeah.
Sorry, dude. You don't. Not everyone needs a fucking 12 lead.
And that's it. You know.
Nowadays they call it, sick or not sick. Back in the day when I took class, it was the oh shit test.
Yep.
You walk and look at your patient and you say to yourself, oh shit, they're getting
They're getting a 12 lead.
They're getting everything. Yep. Yeah. And it's one of those things that when you guys, when you have that inkling to do it, personally, you're utilizing that to rule out stuff, sure, but what are you looking to rule out other than just like MI? Because most people go, hey, I want to know if they have an MI, is there an infarct, or is there a deadly rhythm?
Yeah, that, and also metabolic stuff. I mean, I'm also looking for what's going on in their system. You get your peak T waves, and somebody's been drinking Red Bulls for the past week and a half. And maybe they got some imbalance going on their pH and shit, and their body's just out of whack.
Yeah,
that will show up.
I agree.
And another funny one you can catch is a hypothermic patient. You got those osmolar waves in there. You can go,
Yep. Yeah, and especially, I mean, we've spoken about the elderly people who fall on the cold floor.
Yeah, it just saps them.
Boom. Now they're hypothermic because the AC was running. Yep. And you go in for a fall call and it's 90 degrees out, and it's like, they're not hypothermic, and their core temp is 94, and it's like, hey, look, they were hypothermic. Yeah. One thing that before we go on and we talk about J points and stuff like that, and elevations and all the stuff that Butch wants to talk about, do you guys personal medic to medic,
mano to mano,
yeah. So
what the hell's mano to mano mean?
Are you ones to, okay, there's indication in your mind to do a 12 lead. So being that you're the due diligent, I honestly don't know how I keep saying that correctly.
Drink up.
Yeah, right. Doing your due diligence, you get out your 12 lead cables, you do your 12 lead because there was an inkling to do it, no matter what it was. You don't find anything that you're like, I don't have to do anything.
Yeah.
Do you? Maybe you could turf that BLS. Do you or do you not?
Nope.
So, and I know I've said it to you guys before. I'll say it to everybody now, and I say it to my partners all the time. If you remember cups, because that's when I became an EMT, they were still teaching cups.
What size?
Double D always.
Okay. Yeah. Just making sure.
Please. This ain't the itty bitty titty committee. Wow.
I mean,
and there goes our female audience. Right out the door, changing the channel. Fucking A. All right.
They're laughing.
Good
it's
for
okay.
Me. All right. Fantastic. Yeah, I won't see that in my next, harassment training video. But no. So cups, right? Critical, unstable, potentially unstable, and stable. If I have a patient that is anything but stable, I'm taking it. I don't care what it is. If my spider senses are tingling, if I think there's a hint of instability in this patient's condition, I'm taking it. Mm-hmm. It may not be somebody I've done a 12 lead on. It may be, just something's like, something ain't right here.
Right.
But yeah, I mean, if I'm doing a 12 lead on somebody, it doesn't necessarily mean I'm taking them, but I'm doing something to rule something out.
Right.
And if they're perfectly fine after that, and I've ruled that out, and I know that they are stable, then yeah, I don't mind turfing it. But I mean, I'm actually one of these people. Like, yeah, you're an EMT. You need to be an EMT sometimes, not just a driver.
Yep.
But no, I mean, yeah, if I do a 12 lead in somebody and I still just have this, something ain't right, then yeah, it's mine. I'll take it.
Yep. Butch, are you in agreement to that?
It also depends what system you're in too. Like some systems, once you own that patient's yours. Like once you slap that 12 lead on, that patient's yours. You can't just be like, yeah, we're good here.
Right.
And to me, that discourages paramedics from doing their fucking job. Because then you're going to have paramedics who we know should be on the sick, lame, and lazy list, and they fucking will go, oh fuck, I'm not putting a 12 lead on because
I don't want to do
my spider senses are tingling, but I don't want to fucking. I don't want to take this.
You and I have all we've all seen that.
Oh yeah.
Yep.
Because once you own that patient, it's yours. I mean, even if you don't find anything, you can be like, yeah, we'll turf it down BLS, but no, that patient is now yours, and you own it.
And it's funny because I had the opportunity of riding with Mark and stuff during internship, and he's the type of practitioner that if you had the inkling to do it, it's yours no matter what. Like you can't just be like, nope, even if it's fine, that's yours. There was something that said you should probably do it. Even if you do nothing after that, it's still yours. And that's how I practice. So like it sucks being in the fly car system because like I could turf it. I just I have no spine in being like, all right, you know what? They got some chest pain, whatever, or they got nothing, but the 12 lead shows nothing. Like it's BLS. I'm going to take that in every single day. Everyone who knows me knows I'm going to do that. Could I get away with it? Sure. Have people? Always. Are they going to be fine? Absolutely. But
so, I mean,
I understand. I'm not faulting you for, it's just a different way of practicing.
Well, just as an example, I mean, you have somebody with, what they call, pain or
the GERD
burning, right? And they have a history of GERD and all that stuff. But because it's, they're feeling something here in your chest. Okay, you know what? I'm doing a 12 lead, not necessarily because I think there's something going on with their heart or there's anything more than just indigestion. I'm doing it to rule it out, just to make sure that it's not, because you never know.
Yep.
And then once I rule it out, and I go, okay, hey, everything looks good. You're fucking 75 rate. Everything's fucking on the line. Everything looks great. You're better than mine.
Yep.
And all their blood pressures are good, and everything else is good. Hey, you know what? You don't need me. You have indigestion.
Yep.
Sorry.
Yeah, and we all have those. Those people in our districts that are, they know how to say the words.
Oh yeah.
Oh yeah.
But at the same point, they say the words enough that we're like, bah, whatever. And the first time you don't do a 12 lead, they're actually having whatever, that's been burned too. I don't know. I don't think either way is right or wrong. I just wanted to stir the pot and see opinions, so
I'm just tired of the and I say it as somebody who remembers being an EMT for 2 years,
so long.
Well, I mean, I know you were one for fucking God knows ever, but in my short, little lifespan here in EMS, the 2 years I was an EMT, I remember there were calls that I thought, I should have been in the back.
Yep.
But the paramedic took it. And then everything was paramedic this, paramedic that, and all I did was drive and pick stuff up and put stuff down. And I'm like, well, then what the fuck was all this medical training for?
Yeah.
So now when I'm at work and I have an EMT partner, I want them to do things, Don't just stand there and wait for me to ask you to do stuff. Don't expect that, hey, you're just going to drive all day. No, fuck that.
Yeah.
You got this training. You have some skills. You need to freaking use them. Get in the back. Hey, you know what? This patient is perfectly stable. Go ahead and get on back there.
Yep.
So, yeah, I mean, if I do a 12 lead to rule something out and, like GERD, just as an example.
Yep.
And, it comes back just like I thought. Everything's cool. Hey, you know what, man? Fuck it.
I mean, heck, even your general weakness, you could get away with it on. Like I totally see where you can totally get away with it on. So Butch, you kind of clapped your hands and shook your hands and, ooh yay, we're going to be talking about J-points. So instead of me talking about J-points, why don't you talk about J-points and the whole ST segment?
All right. So when you look at a basic EKG, I think everybody has an idea of what a basic EKG looks like. All the squigglies, all the pointies ups and downs, and
the pointy ups and downs. I love
so
it.
we kind of all got an idea what they look like. So, the issues you have going to the hospitals is you have to kind of know what you're looking for the bad things, like your STEMIs. I mean, we all kind of have an idea: inferior walls, lateral walls, interior walls. I think you touched on one of your shows, basically, the Lisa.
Yep. Yep.
Kind of
girl that's so pretty you'll never forget.
Yep.
Yeah, and especially with I was going to touch on the whole Lisa and reciprocal change, because that really helps people understand. Like, reciprocal change was one of the things that I was like, I don't fucking understand reciprocal changes. And then, Mark sat down, taught me Lisa, and was like, this is where it goes, and this is where it goes. And I was like, oh, that totally makes sense. So yeah, if you understand, your lateral grouping,
right,
your inferior grouping, your septal grouping, your anterior grouping, which I've done videos on, and we've explained it even in the last episode that we did. Yeah, that's going to really help you in a lot of things.
Right. And like I was telling, I explained to Gerard one day, I was like, for you guys, like, when you look at an EKG, what is the first lead you look at for somebody having a chest pain? What do you look at first?
2.
And that was my answer too. I go right to. Well,
I always go to 2.
Until I had this conversation, I always went to 2. This point on, you'll never go to 2 again. I guarantee it.
Well, that's what I'm saying.
First thing they look at is AVL.
Why?
If you look at AVL, there was a study done in 2016. An AVL alone can determine if you have an OMI going on, and almost I believe the specificity of it was 96% of your patients.
Interesting.
Yeah.
Also helps you rule out if you have pericarditis going on. And AVL depression can rule out if you have pericarditis. If it's not, depressed,
Interesting.
pericarditis.
Very interesting.
So
Yeah,
so by looking at AVL, what is it we're looking for to determine right off the rip that we have an inkling that this is going to be
Look for depression and AVL.
Depression and AVL.
The only time you're going to see a difference is if you have obviously your left bundle branch block, because
Right.
that's depressed.
Yep.
But if you have somebody, crushing chest pains, complaining of the ACS symptoms, I go right to AVL. If it's depressed, then I start looking around the other leads, see what I got going on. Start looking for my, other depressions, looking for my elevations. I have literally taken patients to the hospital with just an AVL depression, took it to a cath lab, and they had an RCA occlusion.
Now, are you looking specifically for depressions, or like depressions off the rip, or are you also looking for AVL just changes generically? Like
AVL depression.
So what if there's an elevation?
AVL is usually like a flat or a little bit elevated, but usually AVL is a little bit elevated or depressed, or flat.
Yep. Interesting.
Yeah.
You think about it, AVL is the only reciprocal lead you'll have that is directly located over the septal wall.
That is true.
It's the only true reciprocal lead you have.
So now ask me which lead I look at when I first pull it.
Yeah.
Yeah.
I mean,
Yeah.
hearing it, again, what are we taught?
Yeah.
Go to the one that reads the heart.
Right.
Right? Where's the electricity going?
Yeah.
This makes a lot more sense.
Absolutely.
And
then wait till we get into discordance and.
I remember
Yeah.
those terms. I couldn't tell you what they were.
I didn't know what the fuck they were until.
The words sound hard until you understand what they mean.
Yeah. Like I said, it's been
what
so
they can,
long.
And what they can tell you
Yep.
is fucking mind-boggling.
Now, will we remember it? That's the thing.
You will.
But yeah, so, elevations, I want to talk specifically elevations for just a couple minutes. And then elevation causes, because we're going to get into a couple of the interesting ones with, left bundle branch blocks and PEs and stuff like that. So elevations, when you're looking for elevations, you're looking for it in contiguous leads, 2 or more, right? So contiguous leads are those Lisa groupings, right? So, if you have 1 millimeter or more elevation in 2 contiguous leads, you can say there's an ST elevation, right? So 1 millimeter is 1 small box. What I found out researching for last episode was I never realized that there was a change for ST elevations in V2 and V3. And maybe you can answer why, because I couldn't find out exactly why there is, but it's 1 millimeter for every other lead. V2 and V3 are 2. I never understood why, but that was just something that I found out researching for last episode. I was like, maybe there's a reason.
I know there's, they look at the posterior aspect. So I don't know why they changed the, I
because again, when we learned that wasn't a thing, and that's going back 5 years. That wasn't a thing. It was 2 millimeters of elevation back then of everything. And then they dropped it to 1. So
I think what it is a lot of people are missing those posterior STEMIs. And if you have a true posterior STEMI, you're not going to see it on your 12 lead. Like if it's a true posterior STEMI, because it's so far back from the heart, we send our 12 lead through, you're not actually going to see it. So I think maybe that's why they've changed the guidelines a little bit.
Which is interesting. Yeah. Again, makes sense. So you were talking waves and stuff like that, right? I wanted to specifically talk S waves, right? At times there may not be an S wave. So S wave, correct me if I'm wrong, but to my knowledge, S wave is always considered an S wave because it comes through the isoelectric line. Yes. So if you don't have an S wave coming through an isoelectric line, you don't have an S wave. Correct. Which then can make things harder for ST elevations and stuff like that. But causes of elevation, right? Your typical STEMIs, recall that, again, we talked about it last episode, full infarct, you're talking STEMI. So full thickness through the heart is infarcting, dying at that point. That is your STEMI, your ST elevation MI. ST elevation also can be caused by early repolarization, global pericarditis, right? The left bundle branch, which we're going to talk a lot about, pacemakers, and PEs, and there's things that we should be looking for all of those in our 12 lead. How many of us do? I know that, other than pericarditis,
other than the grand poobah over here.
Right. But
they're simple to check for once you know what to look for.
Right. So what are you looking for at that point?
It depends on what you like. Well, first, I went through and I did some more research to get the most up-to-date information I could. The new stuff coming out now is, like I said, they were saying the old myth was you can't spot a STEMI in the bundle branch. You can't spot a STEMI in pacemakers. You can't spot STEMIs in a bunch of things. Well, the new research coming out is that's all incorrect. And even doctors nowadays are saying, oh, you can't do it. So for, say, a left bundle branch block, you look at what they call discordance and concordance, Q waves and your T waves. Discordant means you have Q waves pointing down and T waves pointing the other way. It's called
in the reciprocals, right?
Appropriate concordance and appropriate discordance. So it means Q waves pointing one way, T waves pointing the other way. So Q waves point down, your T waves point up.
Okay.
That's basically all that means. They're pointing opposite ways.
Opposite ways.
If you have coordinates, that means your Q waves are pointing up and your T waves are pointing up. That's bad.
Okay.
If it's a millimeter, then you have a positive possible STEMI going on in your left bundle branch. So
interesting.
And then the one thing I learned, recently was the why it actually is important to know about the axis deviation. You see right axis deviation, it's the heart finding new pathways from the left because the left is either ischemic or infarcted. And there you go.
Yeah.
That left bundle branch block might be indicative of something pretty fucking serious.
Right.
Yep.
Yeah, because you think about what's happening in left bundle branch block is you usually have a blockage that's not letting the left ventricle pump properly.
Mm-hmm.
And what's happening is, it's going down the pathway. It's not going to the left ventricle, going to the right ventricle, and then through, depolarization, it goes through, and then it polarizes the left ventricle through, mitosis. Boom, there you go. So you're getting irregular heartbeat. It's not doing good. Eventually, your heart's going to say, yeah, we've had enough of this. Eventually, somewhere.
Right.
So, yeah, you're going to have to, so there's nothing really in the rig that we can do to fix that. If your patient is stable, look at your heart rate, see if you have the elevations in there. Like I say, concordance, discordance. If you have concordance, call in and say, hey, got a possible STEMI going on here. If you have discordance, if it's more than what they call 5 millimeters, and they go in this whole explanation like, oh, if your S wave is down below so many, if it's up so many,
right from the bottom of the one to the peak of the other.
Yeah, the bottom of the S wave is down so far, and up to the J point is so far. The best explanation that I heard was count how many boxes you got going down in your S wave.
Mm-hmm.
The big boxes.
Yep.
Those are 5 millimeters.
Yeah.
Then you go to your isometric line, count up to your J point. If it's more than half of the number of little boxes as the big boxes, it could be positive for STEMI. There you go. That's the best explanation I heard of it, other than trying to do the math and
Right.
Yeah.
So best explanation I heard.
Yeah.
Because Lord knows we don't want to fucking math.
Yeah, if you have three big
Fuck
boxes,
that shit.
yeah, 3 big boxes down, and you have 8 big boxes up. Hey, you got could be indicative of a STEMI.
Yeah. And
That's
is
for your
that
discordance?
And so, are you looking at that in every lead, or are you looking in that in specific leads?
Only has to be in one with the left bundle branch block.
Yeah.
Interesting.
Yep, only's got to be in one.
Yeah.
Interesting.
But if you have it in one, you're probably gonna have it more.
Right. Right. Because most of the time when you're looking, left bundle, you're already looking at something that is typically wide, typically elevated and stuff and you're just like, I don't know. It's like looking at a pacemaker rhythm, I would hope that somebody, inevitably when I have my cardiac STEMI or whatever from drinking all those years of Coca-Cola and shit, I would hope that my pacemaker's still going off at that point. And, how are they going to know?
Good point.
Because a lot of times you have the people like, me, that my pacemaker's going off. And then, especially now, like no one would know unless you feel my chest that I have a pacemaker.
Right.
The big block is gone from 1980. Mm-hmm. And, now it's like, okay, well, that looks really bad. The fucking Zoll monitors don't even pick up a pacer spike.
Yeah.
So unless you're really looking for an actual spike on the 12 liter, on the 4 liter, whatever, you don't know, but it surely looks like
buried in there too. I mean,
damn skippy they can, and you're really looking hard. You're just like, yep, they're dying. They're having a STEMI everywhere. It's like, no, maybe.
Right.
But more or less not. So, with the pacemaker, does it kind of go along the same route as with the left bundle branch block? Or are you still looking for that?
Yeah, you still look for the elevations, but make sure you know what you're looking at. Yeah, obviously your doc in the box is going to spit out, oh, this is a pace rhythm.
Right.
And a lot of people are going to stop there and say, oh, it's just a pace rhythm. Yeah, we're good.
Yeah.
But then you have to do a little, detective work and see, if the elevations are there, if they're, you have to have the discordance or, coordinates to make sure, we're good. It may be subtle.
Yeah.
And you may have nothing, but you have to do the detective work to make sure.
And I kind of feel like that's all of 12 leads is just being a detective on all this stuff.
And then the one thing that, with all this, and it's real easy to get sucked in, because I've literally been sucked in, just buried into a fucking 12 lead trying to figure it out and trying to figure out what I'm looking at. And, you got to take that step back and say, okay, all this good gobbledygook. And then you have to go, oh, let me look at my fucking patient.
That's right.
What is my patient doing? What kind of signs and symptoms do I have?
Yeah.
Yeah.
Every 12 lead has a patient. Look at your patient.
Yeah.
If they're stable, numbers are stable, then you can be kind of like, okay,
right.
We got some time to do some things.
Yeah.
Yep.
If they're fucking ashen and they got the holy shit fucking save me look on their face, probably a good idea to get a move on.
Yep.
You know?
Yeah.
You know?
So another big one I feel like we miss with the whole ST elevation is pericarditis. Now, not something, again, that we're going to do a whole lot for.
If anything.
Right. Yeah. Again, they need antibiotics. They need, all this different kinds of stuff. But,
They need the big blue H.
Yeah.
I mean,
got nothing to do with me.
The good thing with pericarditis is it's relatively rare. I mean, you're looking at 2 to 5% of your population is going to have true pericarditis. Yep. And it's
Mark's a statistic.
It's going to come with history
I'm
of that
a
patient.
statistic now.
Yeah, y'all.
It's going to come with history of that patient. Like, have they had a recent illness with fevers and So getting a good history on that patient is going to help you diagnose what that EKG you're looking at. Mm-hmm. And with the AVL, that's the same thing. You look at the AVL. Is there depression? If there's a depression in there, probably not going to be pericarditis. If there's no depression, you can say, okay, I think we got just some pericarditis going on here.
Yeah. And pericarditis usually has global ST elevations. It's not in a, grouping of leads. It's everywhere.
All of them. Right. Yeah.
I've never seen one in the field. I've seen them in textbooks.
Well, and that's it. I've Googled them. The only one that I've seen is Mark's because cool.
Yeah.
But is there any indication for like early repolarization or like a vasospasm or anything like that because I know those are again two different things that can show ST elevations and they're not STEMIs. But is there any specific indication or are they just going to be again global or specific to a lead or something like that?
So early repolarization, in V2 and V3, if it's true early repolarization, you're going to have either an S wave or you're going to have a J point. You cannot have repolarization without an S wave or without a J point. Mm-hmm. If you don't have one in either V2 and or V3, start looking at your STEMI issues.
Yeah.
There's also a thing called QRS deterioration, I believe it's called. I written down. And that basically means that if you do have the J point in there, it's not going to come back below the isometric line with that swooping elevation. Look at your STEMI.
Interesting.
Cool.
The more you know.
And now you know enough.
To be dangerous. And be like, I don't know what I'm still looking at.
Yeah.
And that's the again, fun thing.
I mean, and literally, I can't stress it enough, but yeah, once you do all this stuff and you learn some new things, learn some new interpretation rules and stuff. But yeah, man, at the end of the day, don't forget, look at your fucking patient.
That's exactly
right.
Yeah. Like we can teach you cardiology all day long about STEMIs and this and that, and it's literally look at your patient. If your patient looks like shit, do some things.
Yeah.
If they're complaining of crushing chest pain, the elephant's sitting on my fucking chest and my arm hurts. Yeah.
Mona.
There
you go.
Mona.
Go to the hospital.
That's it, man.
Yep. That fucking home Mona.
Yeah. It's funny. I was just thinking about, people that I normally do, 12 leads on. Yeah. Any diff breather. If I have anybody with difficulty breathing, I will do a 12 lead on.
That's what I said in the beginning.
Oh, is it? I missed it. I was thinking about Kelly. She's sitting really close to me right now. I think she's doing something on the table here.
I mean, I think the luxury the docs have in all this is they have a hospital full of people.
Yeah.
And they can say, hey, look at this 12 lead. What do you think?
And the hospital isn't bouncing down a road.
Right.
That's true. And again, I was actually going to bring that up. How much does artifact really get in the way of 12 leads?
I mean, you can play with the,
because I mean,
stuff,
it's
just always going to fuck it up.
It's always going to be there. I mean, I messed with Kelsey. I did a 12 lead and on a patient. She wasn't interning at the time. And I was just like, I'm going to take a picture of this. And I was like, here you go. What is this? And we hadn't talked about artifact yet. So it literally was like complex. Complex. Yep, exactly. And I was like, okay, what rhythm's this? Just say your throat job joke. I know you want to. That's why I did it. Come on. I led you there. Just take it.
The only one in this room that makes that sound is Kelly.
So, but yeah, like, and she literally was like, I have no idea. She was at clinical or whatever.
Right.
And she's like, I Googled this shit. I'm like, it was just artifact. She's like, I fucking hate you. Right. I'm like, but that's, again, what you're reading through, just bouncing down the road.
And after a while, I mean, you kind of learn, to look between the fucking bouncing squiggles and, you know what's a squiggle and what isn't and where the squiggle should be and, and that kind of stuff. But
or you get the people with the girth that the leads kind of just go blah, and you get,
Yeah.
Yeah.
Or you get the real hairy motherfuckers. Oh.
Yeah.
Yeah, you really got to do
those
a good job.
Horrible shoulder hair,
Yeah. The ones you just keep shaving and the hair just doesn't stop coming. It's like, oh my God.
Yum.
What are you doing?
Bouncing down the road and saying, check patient.
Oh my God.
They're talking to me.
I fucking hate that.
Check patient.
That drives
no
me
pulse.
Because then the patient's like, what's going on? I'm like,
nothing.
$30,000 paperweight.
Must be his old.
Don't worry about it. You're just fine. Keep breathing.
So true though.
In the immortal words of Denzel Washington, breathe, dog, breathe.
Am I going to be okay? Yeah, hold on. Let me just push this button here. Okay, you're fine now.
Yep.
Look at that. Fixed it. Fixed the whole thing.
Turn the right off. You're good.
Right? Why is the screen blank? Oh, you can only see it with nods on. Trust me, you're fine.
Put it in night mode.
Right.
Yeah. So moving into just overall depressions, right? Not just AVL, but depressions in, two contiguous leads. Your 0.5 to over 0.5 millimeter depressions is what you're looking for. I deep dove into depressions because, again, you learn depressions are ischemia, and that's where it stops.
Yeah.
You don't learn anything else.
Right. That's all they teach.
That's all they teach.
Yep.
Yeah, it's before an MI and it's ischemia and the heart don't like it. So give them
you have
oxygen.
elevations here and depressions there. You have this and you have that involvement. Okay.
Right. And
cool.
that's where they stop.
Now I know how to sound smart when I talk on the radio. Whoop-de-fucking do.
Right. I never realized that there are actually 3 types of depressions. So there's horizontal.
Seasonal.
Yeah,
I'm
right?
sorry.
There's horizontal, there's downsloping, and then there's upsloping. I had no idea about that. However, the horizontal depressions are the only ones that are caused by actual ischemia of the heart muscle. Whereas upsloping, and then the upsloping followed by like peak T waves.
Those are called the winters.
Yes. Specifically.
Like I said, seasonal. Sorry. That was in poor taste and not very funny.
No.
Okay.
So, an upsloping depression followed by the peak T waves, specifically in V1 through V3. Signs of that left anterior descending occlusion. Never knew that, right? And there's some specific causes for depressions other than just ischemia. There's still the left bundle, right? There's DIG, right? DIG toxicity,
Yep.
right?
There's something we don't fucking think or talk about very often
People
anymore.
are still on DIG. I literally had a patient 4 days ago on DIG, and I was like, you don't see DIG very much.
Right.
But DIG toxicity, that's specific. That's a U-shaped downsloping depression.
See, that one I actually remember.
Yep. Reciprocal changes, the posterior MI, which, he already alluded to, the end-STEMI, right? The partial thickness myocardial infarction, and then just strain on the heart muscle due to hypertrophy can also cause depressions. Cool. Never was taught a single one of those. Like, you wonder what these fucking classes are for. That's why I say I almost feel like you need another cardiology class after you're a paramedic.
I mean, literally the whole AVL depression thing. I mean, honestly, if I see a decent depression in AVL now and nothing in anything other leads, and my patient's complaining of some kind of chest discomfort or some kind of shortness of breath, anything along those lines, I'll call the fucking alert right there.
Yeah, transmit it up.
A couple weeks ago, I wouldn't have done that.
Yeah.
Right now, I will.
Yep. Now
especially when it was specificity was at 90-something%.
Yeah.
Now, is that something that you're going to get laughed at by the doc on the phone? Because we all know the baby docs.
Not
they're
when
gonna,
I explain it.
Yeah, but how many providers are actually going to sit there and be like, well, according to this study in 2016, blah, blah, blah. Like, exactly. Like,
Yeah, push it.
how many of them are actually going to do that?
Yeah.
They're going to go, they're never going to believe what I say. Let's just transmit, see if they catch it. And then they're going to be like, nope, it's fine.
This is where your serial EKGs become important, like at the house, and to the hospital, at the hospital. Bang out as many as you can. Like, one EKG's not going to,
I think I did 5 on my partner the other day.
That's where they become important.
Yeah.
Serial EKGs.
Yep.
Yeah.
See the change.
Yep.
Killing my partners one at a time.
Don't tell people that. They'll stop working with you. But
You mean then I don't have to work?
you'll still have to work.
I can just sit at home and drink 40s all day. Be great.
The loco.
Oh, so funny you say that.
Oh, fuck.
Oh, Jesus. Here's the wormhole.
I'm sorry.
Go to a fucking call a couple weeks ago.
No, they have Four Locos on the ground?
Drank 2 Four Locos in an hour. Not feeling well. I report it on when I make the call to the hospital. Yep, 2 Four Locos in the past hour. Literally, dude on the other line goes, "They still make those?" Yeah, apparently they do.
Nice. Yeah. So yeah, let's like break down the whole depression thing, because we talked about elevations.
Add to depressions too.
I would love for you to add to the depressions.
What is the one lead in our 12 leads of 12 leads that is pretty much the orphan child?
12 lead of 12 lead.
AVR.
If you have AVR elevation and you look at the rest of your 12 lead, you have diffuse ST depressions, it's very indicative of some kind of occlusion going on.
Nice.
See,
just nothing to add in there. I found. I didn't even know about.
Fuck these people.
I found about it too.
Right?
Yeah. It's just it's one of those leads that it's often overlooked. You're just like, whatever.
They literally tell you don't need it.
Yeah.
Almost verbatim. Yeah, don't ever worry about that one.
Exactly. This is literally what they told us.
Don't ever look at that lead. It's just
don't ever need it.
Yeah, it's just there.
If you have diffuse depressions and every other lead, and you have an AVR elevation, probably might want to get a cath lab on that line, because you're looking at a pretty good probability of having some occlusion.
And that's why, when you call and you get a fucking baby doc or something that is saying saying that what you're saying what you're sending them isn't what you're sending them. That's where having this ability to explain this shit
really comes in handy.
You know what I mean?
Yeah.
And if they still got a fucking issue with it, then that's when you do what our other friend told the one doctor that one day and said, "Put your father on."
Yeah.
I think the problem is there's like no accountability. There's no QA QI committee between agencies and doctors. Like, bigger agencies actually sit down like quarterly with the hospitals and say, okay, let's go through STEMIs. Let's see who you activated STEMIs with.
Right.
And they actually sit down with docs, like cardiologists and like their medics and stuff, say, let's go through the strips, and they figure out, yes, was this a good call? Was this not a good call? They check out patient outcomes, and they do that, and that's how they get better. Around here, it's like you might get an email or a follow-up in your chart, like, your patient,
died,
came in.
Yeah.
They gave him fluid. They found a thing out, and then they sent him up to the ICU, and that's what they did.
Yeah.
Like, you never get a follow-up on if your activation was
proper,
was good,
warranted, proper. Like, how did it work?
Right.
Yeah. No, it's true. There was a girl that I went to high school with that started working for the AHA in the research division.
Oh.
And again, not my cup of tea, but really cool job, because
that's kind of cool. Yeah.
Her whole thing was the chain of survival. She was researching how that chain actually provided better outcomes. And this is almost the same thing. Like, does our activation early, does our 12 lead, obtainability within X amount of minutes, does our transmission to the cath lab and the ERs, do all of that actually, along with our ACLS protocols, change outcomes? Make it better, make it worse, don't really do anything of, any sort. And yeah, I think that that's something that, the state or, in our area, our region or something should be looking at, because, these calls do happen. They don't happen to me, but they happen,
right.
Seriously.
Everyone just looks at me.
Yep. But yeah, I mean, it's looking at all of the possibilities, now, again, knowing these things, you look at 12 leads a little differently.
Yeah.
And then there's other ones that, like your STEMI equivalents that people don't think of. There's a mnemonic out there called How Bad. You think about your hyperacute T waves, just for anything, hyperkalemia, and there's a guy, Dr. Stephen Smith, who's figured out a whole formula. It's a 4-variable formula. There's an app. You can go on the app and look it up.
I love apps.
It's
They
based
make
on
math for apps.
Right.
It's based on our way. Your
Apps for math, you mean?
Whatever. Just leave me alone.
They make maths for apps. Wow.
I kept
You mean
drinking.
I actually got to sit there and do math before I can fucking use the app? Fuck.
I kept drinking.
That sounds like a $1 million idea.
Now say due diligence. Go ahead and say it. Due
No,
diligence.
I can still say due diligence.
There you go.
There it is.
Yep.
There it is.
Yeah,
Haven't caught me yet.
the whole figuring out the hyperacute T wave is based off your QTC and the R wave progression in V4. And there's an app. You put in the numbers, boom, and it can figure out if there's a possible STEMI going on. And it's published in journals, and I actually have the app on my phone. But and you have your out of hospital cardiac arrest. It could be a thing. And there's no protocols for that either. Like if you have a patient that's had a cardiac arrest, there's systems out there that have actually when to notify the cath team, when not to notify the cath team. Like, is it prolonged downtimes? There's a whole into that. Like if you had a patient that's been down for 30 minutes or so, are you going to activate the cath team on that patient?
Yep.
When you take them to the hospital, is that patient? I hate to say the word, but are they viable after that point in time? You get Ross back on a patient who's been on 30 minutes.
Yeah, no.
Do you want to send them to the cath lab?
Yep.
Then you have your Welland syndrome. How you check those out. Check for your those lovely little.
This doesn't help people with
the symmetric.
Don't waggle your finger at me. You don't know where that finger's been.
helps my visitors.
Why are you sounding like Sean Connery all night?
It's like
really?
Connery in the brain. Yeah,
That was a Connery.
Not that deep,
Oh,
but it was an accent.
I'll take the rapist for 200.
Anal
Anal bum covers.
like your symmetric T waves. They're nice symmetric T waves. Welland syndrome can be a sign, and usually that's an early sign of something going on. They have two types. There's type A, type B. Welland syndrome is type A is the nice symmetric T waves. Type B is more of a flat kind of flat T wave that kind of rounds out at the end. And you'll post pictures. I can send you pictures of what they are so that you can post them. People can understand what I'm saying. Those are much easier to see by, that's what it is.
Yeah.
That's a very early sign of, hey, there's something going on here. I need to, get on top of this, because once that hits, usually it's a posterior kind of thing going on, and when they hit, those T waves go out of control, and that's a bad thing.
Yeah.
Then you have your bundle branch blocks, the AVR STEMIs, and then your DeWinters. So that's the how bad syndrome, the mnemonic.
Which again, that's one that I'm going to do a full on post about that one, just because I might even do just a regular video on that one, because that's not. I love learning new mnemonics with EMS, because there's so many.
We don't have enough.
Exactly, we don't have enough.
More.
And but I love learning about them because they're freaking cool. Gerard, any questions from you?
Wow.
I mean,
here's the spotlight. Fucking here.
Yeah.
Wow.
I mean, Butch has been talking for a long time now.
So here's something that has kind of been gnawing in my head recently because of a couple of really recent calls.
If you poke at it and it changes colors, get it checked out.
Say what?
If you poke at it and it changes colors, get it checked out.
Okay. All right. Well, I got nothing to say. Okay. The slurring of the ST segment. Mm-hmm. I've had a couple people with this recently with slurring. One completely asymptomatic. Another one was complaining of, some issues. And I was very hesitant to call any kind of alert on that.
Okay, so there's a slurring pattern that occurs.
Even though I meant to say, I'm sorry, the one that had the slur, it was elevated, but it wasn't more than a millimeter. But it was definitely not on the isoelectric line. No,
there's a slurring of an ST pattern. If it's diffused all the way through, they usually don't tend to count that as a thing. It's just it's a polarization kind of situation going on, the repolarization kind of situation going on. When you start looking at more of the lateral leads, and you see that polarization looking more like a flat line as opposed to that cupping situation,
okay,
that's when they start being more concerned because they should be more rounded. But when they start flattening out, that means that repolarization is not effective there, and that there's something in that heart muscle that's irritated.
Gotcha.
So that's when you start looking at what's going on.
Yeah, because one of them that I noticed, the P wave was it was there, but it was didn't look like it wanted to be there. And then it just had that weird little slur to it, and it was just above the isoelectric line, a little box.
Yep.
Maybe 2 little boxes tops. Mm-hmm. But and I was looking at that this week, and it was I took them into the our cardiac place instead of the local place, but I didn't call an alert on it or anything like that. I just
that's still in your early stages of going into your STEMIs and going into your VFib, stuff like that. But start watching for those flattening out of those ST segments, because then your heart's starting to.
Yeah, it was like one of those things, like we were talking about the spider sense.
Yeah,
that was one that was making me tingle, and I didn't know why.
Right.
I was like,
there's something going on, but you can't put your finger on it. Yeah.
But again, look at your patient. If your patient looks like crap, it's a good indication that there's some crap going on.
Yeah. Yep. And that's what it was. I literally just was like, well, something, and of course the monitor was telling me some fucking bullshit. I'm like, all right, whatever. The patient was like, yeah, just feel a little sick to my stomach, and I got this weird, feeling in my chest, and I was like, oh, okay, that's good enough for me.
Yeah. And that's one thing I learned too. I was like I say, I was just looking at stuff, trying to get the most updated information, and it's like one of the guys I follow sometimes on YouTube, he's throwing out there. He's like, a lot of medics don't like reading doc in the box. Like they spit out the interpretation. You're like, I'm smarter than that. But look at your interpretation sometimes, because that can lead you down the path of where to look on the EKG.
Which is so funny, because I always had the opposite opinion, that a lot of paramedics just looked at the doc in the box.
That's true too. Unfortunately, that is true.
I would not have the opinion that most of us don't.
Yeah.
I look at it and I'm like, okay. And then I look down and I'm like, okay, what do I really see? Does it match? Does it not match? Our old agency, Gerard, QI'd a chart from mine where serial 12 leads all said STEMI, 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 STEMI. Yeah. None of them were.
Right.
And I was like, nope, not calling this in. But the doc in the box was like STEMI, STEMI. And I was like, nope.
Ventricular pacer?
No.
Really?
No, just generalized chest pain. But for whatever reason, maybe it was the way I had the leads or the way it was reading or whatever, it spit out STEMI every single time. And I was like, no.
Or maybe knowing some of our new rules, go back and look.
Maybe it did.
Maybe there was something
maybe
there.
There was a posterior going on or something that
maybe there was an AVL depression, but because we never look at AVL until now.
Until now.
Right.
Maybe. And that's it, And, so I think there's definitely things that, paramedics have been branded
Yeah.
for being doc in the boxes.
Well, I mean,
You
so
know?
so when I get a printout, the first thing I like to do is just do my interpretation. Q's for P's, P's for Q's. Do our whole thing.
Do your rules.
Do our rules. Everything on the line. If it's not, where is it? All that good stuff. Just the basic general rules.
Yep.
Then I will go look at what the computer's telling me.
Mm-hmm.
And if it jives with what I'm looking at, and then it tells me something that maybe I didn't know or didn't see, like now we're talking about all the axis deviations. Well, those things pick that shit up pretty fucking quick.
Yeah.
So now if I start seeing something, oh, hey, look, they got a left bundle branch block. And I look, oh, look at that, right axis deviation. Hey, guess what we're doing?
Yeah.
So
what's your opinion on, I mean, we've been all talking about left side 12 leads, but what is your opinion on right side and posterior 12 leads? Are you like, they should be done in these situations 100% of the time, or are you kind of just like, yeah, if you get around to it, you get around to it?
I've done V4R once, but I've never done a posterior and I've never done a right-sided. And now, I mean, hindsight is 20/20. There were more than a few I probably should have,
I've done right-sided on people when I've had time. I've never done posterior because a lot of times they're doing the
right. They don't want to move.
Here, I'm gonna sit up here and just put a bunch of stickers.
Right.
On. I've just never done the posterior on something.
Yep.
I mean, I guess if you're suspecting the posterior, going on, yeah, slap on the back because that's your best view of that side of the heart.
Right.
Otherwise, I mean,
and again, it's one of those things where like, hey, it's really cool to do a posterior 12 lead. Hey, it's really cool to do a right side 12 lead. But what are you actually looking for? Because the view changes, so, you're putting leads in different places, so are you looking for the same things in the same leads?
So remember, when you go to V4, when you go to the RVR side,
Yep.
everything you look at over here is going to be basically
A mirror.
flip the script.
Yeah.
Right.
So if you have elevations here,
You should see
you
depressions
should
on the
see
other side.
depressions there.
Right.
If you don't, you're not going to cath lab. You're
Yeah.
going to surgery. You're getting cabbage.
Yeah.
I mean,
Now, what about posterior, though?
there used to be an old school trick with your posterior leads. Like if you look at V2, V1, V2, V3, and you're seeing some depressions, and you flip that over, hold up to the light, and you're seeing some elevations, and you put that on the posterior leads, you should see elevations in those leads too. Old school trick
Okay.
back in the day.
Cool.
Back
You
in
should
the-
see that if you go back, and you shouldn't have to do the full 12 lead on the back. Just do like V8, V9, maybe V10, and get that same. You know what I mean?
Yep. Very interesting.
Cool.
Anything else you wanted to add? That was my only question, was just to pump through those. I would say that we have to invite Butch back,
Yeah.
just because I'm sure that people, I'm going to put it out there to listeners. Again, follow the Facebook, follow the Instagram. You'll see pictures of everything that we're talking about here. But I'm going to put it out just to say, what kind of cardiac stuff do you want to talk about next? Because this is a subject that, again, I am horrible at left versus right bundle branch blocks. I am terrible with, hey, is it bunny ears? Is it not bunny ears? Fuck that. And I constantly review that so I don't forget.
Right.
Is there a different way of doing it, now than when we learned it? So it's constantly changing and stuff. And, I'm fully in admittance like you.
Yeah.
I am not strong in cardiology, but I work on maintaining where I am so I don't get worse,
Right.
Or I get better. And, as providers, we kind of have to know where our weaknesses are and work towards strengthening those.
And be honest with yourself,
Exactly.
To thine own self be true. I mean, fucking,
Right.
I'll put my hand up first. Yeah, fucking cardiology, I suck.
Yeah.
That's my weak spot.
And that's okay. So yeah, I think, having another discussion, putting it up to comments and votes to listeners and being like, hey, what do you want to hear about from Butch next? Let's do it.
Yeah.
I'm all for it.
Sgarbossa.
We didn't talk about Sgarbossa today, but that's a long conversation.
Yeah.
Not
I
just
touched on it briefly with the the
right.
Portiston, but
Yeah. Sgarbossa
that
is
actually
a thing.
is really, really fucking interesting.
Sgarbossa is awesome.
Then you got the modified. All that, yeah, it's.
There's a modified
Oh yeah,
Sgarbossa.
with a point
Smith modified
system.
Sgarbossa.
Oh, see, I didn't know that
it's,
one.
It's pretty cool. Yeah.
Interesting.
Yeah, the
See?
Sgarbossa was the first one with the point system. Then
Right.
Then Dr. Smith came in and said, "Hey, wait, we can make this a little easier." So
Fuck, I need to learn that one now.
Yeah.
it's
But-
much easier than
And it makes so much sense once you learn it.
Yeah. Well,
It's
that's
like,
it.
Holy shit.
You
Wow,
know?
why the fuck didn't I learn this fucking years ago?
Yep.
come back in and have a chat about that too.
Yeah. I'm all for it, and I'm sure everybody would be too. So,
I think once you get the pictures, the pictures posted, and
damn Skippy.
That's when he's
say, "Hey, wait, we're looking at
yeah, it's when he's not busy, caddying for the Dalai Lama. Yeah, he's out there. Yeah. He's got a big hit of that Lama,
There's trouble. Something for trouble. Yeah.
Yeah, hey, when he dies, he's going to achieve total consciousness, so he's got that going for him.
There you go. Good for you. Good for you. So till next time, guys, stay strong.
Depressed AVL donuts.
Oh, yeah!
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.